I got nothing. So why are we talking about cerebrovascular accidents in the second week of cardiac talks? Well, it might surprise you to know that most strokes have as their underlying pathophys atherosclerosis. It's exactly the same process that gives us our heart attacks. And that's the vast majority of strokes. They're dubbed ischemic strokes, and they are due to the process of atherogenesis, progressive plaque formation, and then the plaques themselves either occluding an artery within the cerebrovasculature or a portion of the plaque breaking off, embolizing, and then causing blood flow disruption further upstream in the cerebrovasculature. That's the vast majority of strokes. The minority of strokes is literally the opposite of that. Hemorrhagic strokes. A blood vessel ruptures and there is literally bleeding into the brain. Two types of strokes, completely opposite phenomenon. The majority, deprivation of blood flow. The minority, a bleed right into the brain. But I'd be remiss if I did not introduce you to common stroke terminology because you just got to have it. It's just there. And one of the most common terms you're going to come across is TIA, transient ischemic attack. Your patients will probably refer to it as a mini stroke. But technically, it's not a stroke because it is temporary. It's transient. There is no permanent death of brain tissue. A clot in the cerebrovasculature is the most common form of TIA. And if it's small and just temporarily occludes a small portion of the vasculature, the patient gets a symptom. Maybe the symptom is vision changes. Maybe the symptom is momentary weakness or change to the sensation in a limb or an extremity or a finger or toe. But it lasts a very brief period of time, less than 5 minutes. However, patients who are developing TIAs are considered to be at risk for a more catastrophic cerebrovascular accident in the future, and therefore need to have care planned accordingly. So here we have kind of a compare and contrast between two relatively common sources for an ischemic cerebrovascular accident. On the left is atrial fibrillation and its potentiation of an ischemic stroke. As the atria fibrillates, they're no longer moving blood efficiently out of the atria and into the ventricles. When atria don't move blood efficiently, that leads to the potential for blood stasis. Whenever I say blood stasis, your little Virchow's triad flag should go up. Ding, 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 ding. Blood stasis could equal a clot. And that's exactly what these folks are at risk for. Intracardiac thrombi. If that cardiac thrombus forms in the left atria, just like a DVT, there's a risk for a piece or all of the thrombus to break away from the atrial wall and become an embolus. Well, it's on the left side of the heart. So if that embolus then travels downstream to the left ventricle, the left ventricle could shoot that thrombus out into the systemic vasculature. One of the places it could end up is in the brain. And as the arterioles get smaller and smaller in the brain, eventually that clot's going to lodge in somewhere and stop blood flow. So that's how atrial fibrillation may lead to an ischemic stroke. It's also the reason why atrial fibrillation patients are put on some pretty strong blood thinners to prevent intracardiac thrombi. Now contrast that scenario with carotid stenosis. A lot of your patients will have atherosclerotic plaques within the common carotid arteries or the internal and external carotid arteries. As these plaques enlarge, they're slowly reducing the lumen, thereby reducing blood flow to the brain. One of two things could happen. They themselves could completely occlude at the level of where the plaque is, or, as we learned from learning about atherosclerosis, bits and pieces of the plaque can break off, form emboli, and those can be sent up into the brain as well. Here's two concepts that I do like to introduce people to: core ischemia and ischemic penumbra. When a patient has a cerebrovascular accident, a stroke, and brain tissue dies, those neurons do not come back. However, even though the center area of necrosis isn't going to come back, there may be areas around the area of necrosis that may be savable if blood flow is restored in an adequate time frame. This is why strokes are considered medical emergencies. All right. The core of the stroke may be dead tissue, but if the first ring around the stroke is deprived of 70% blood flow, if that blood flow can be restored, you may save brain tissue. Now, strokes are not without their complications, just like myocardial infarctions are not without their complications. For example, if people have a stroke, that can then induce an inflammatory response. The inflammatory response always includes some type of swelling or fluid collection, but in this case it's in the brain, which is a closed vault and can't handle a lot of excess fluid very well. Edema in the intracranial vault increases intracranial pressure, and the increase in intracranial pressure can actually push on the vasculature within the brain, and that pressure on the vasculature can actually cause a reduction in blood flow. That reduction in blood flow obviously reduces then oxygenation and oxygen delivery to brain tissue, so it becomes a little bit like a positive feedback kind of thing, where you have the stroke, it sets off this inflammatory response, but then the inflammatory response itself then increases the potential loss of blood to the brain. The end product of this is a catastrophic event called anoxic encephalopathy. Break down that word. Here's another complication related to inflammatory mediated edema. Patient has the infarction, the inflammatory response kicks in, edema is generated, it increases intracranial pressure, and then that leads to brain tissue being pushed around based on where the fluid is within the intracranial vault. If the brain happens to be pushed downward displacement of the brain, what can happen is the base of the brain, where we have all of our most basic controls, for example, the stimulus to breathe, can be herniated or pushed downward right through the foramen magnum. This type of brain displacement can lead to a reduced level of consciousness and vitals and potentially death if it is not intervened upon. As a matter of fact, patients who have intracranial edema and who are at risk for the edema causing downward displacement of the brain are monitored for what's called Cushing's triad. And yeah, it's the same Cushing for which Cushing's disease is named for. Harvey Cushing. People just gotta have their names attached to everything. Cushing's triad is a high intracranial pressure assessment, and the signs of Cushing's triad include bradypnea, which is slow breathing or just irregular breathing, bradycardia, slow heart rate, and compensatory hypertension. Why did I say compensatory? Because the body will try to maintain brain perfusion at all costs. So if the brain is inadequately perfused, as it may be in the setting of intracranial pressure increases, there will be systemic vasoconstriction to try to push more blood up into the brain. So the hypertension in Cushing's triad is a compensatory mechanism. And we know in this class all about compensatory mechanisms, don't we? Another clinical term I do want to throw out because you're going to see that is lacunar infarcts. Remember how I said TIAs will be dubbed mini strokes by a lot of patients? The truth of the matter is lacunar infarcts actually are mini strokes. The vast majority of them are found incidentally. They are true tiny strokes that are usually only found when a larger stroke happens and then the brain is imaged. A few of them actually produce functional loss, somewhere around 30%. What that means is 70% of them completely asymptomatic. And yes, if you're thinking of the spectrum of severity that we bring up a lot in this class, hopefully you're now coming to appreciate that myocardial infarctions have a spectrum of severity to them. Strokes have a spectrum of severity to them. When lacunar infarcts are looked at, sometimes posthumously, microatheromas are found. And so this does lend itself to the idea that atherosclerosis is probably the underlying source of what's going on here. There's also this phenomenon called lipohyalinosis, which has to do with eosinophil deposition in areas. In my opinion, this is a correlation or an association with regard to lacunar infarcts, and there's probably more research that needs to be done to evaluate the contribution of lipohyalinosis to the development of lacunar infarcts. Interestingly enough, people with lacunar infarcts are known to have a higher risk for vascular dementia. And if people do have these, it's definitely considered to be kind of similar to TIA, potentiating the possibility of a larger cerebrovascular accident later on.
I be stroking, that's what I be doing. I be stroking, I be stroking, that's what I be doing. I be stroking.
So most of this talk basically was about ischemic strokes because the underlying pathophys of an ischemic stroke is the same as it is for myocardial infarctions, peripheral arterial disease, and it is the atherosclerotic process that many of us have occurring in our bodies right now. Just for purposes of contrast, I will talk about cerebral hemorrhages, the minority stroke category. As the name implies, this is a bleed into the brain. Both ischemic strokes and hemorrhagic strokes can be catastrophic. They can also be very, very tiny as well. So the spectrum of severity does apply here too. In ischemic strokes, we were worried about inflammatory edema causing brain displacement. In a cerebral hemorrhage, as the bleed kind of solidifies into a big mass, a hematoma, that too can displace the brain as well, leading to increased intracranial pressure and leading to the necessity for monitoring for Cushing's triad. The hematoma of a cerebral hemorrhage can be removed surgically if necessary. To some extent, though, the body's own cleanup mechanisms work as well, and the blood clot can be absorbed through the natural cleanup processes that we all have. Because strokes are a medical emergency, we do need to know a little bit about the diagnostic workup, and the sooner we know about this, the better. Also, the more times we hear it from our teachers, the more it sinks in. Strokes present quickly. The acronym FAST is oftentimes used for kind of a layperson's clinical assessment. When a patient with a suspected stroke arrives to an ER, the first thing they need to do is get imaging of the brain. The main reason they do this is because there's a big question that has to be figured out. Is this stroke ischemic, which is more likely, or is it hemorrhagic, less likely? The reason this is so important is because it helps dictate treatment. Patients who have ischemic strokes may be eligible for clot-busting drugs, such as TPA, tissue plasminogen activator. The side effect of those types of drugs is bleeding. Would you want to give a patient who had a hemorrhagic stroke a drug that can cause bleeding? No, that would be bad. That would make things worse. So that CT is going to help discriminate between ischemic and hemorrhagic strokes.